Hi, I'm Dr. Estela Rodriguez. I'm clinical research lead of thoracic oncologist at the University of Miami Sylvester Cancer Center. And today we'll be discussing small cell lung cancer treatment beyond progression for patients who have progressed after platinum-based chemotherapy. So small cell lung cancer, it's not the most common cancer. It accounts for 10 to 15% of all lung cancers. Fortunately, the age-adjusted incidence rate in the United States has been trending down, and that's mainly due to decreases in tobacco use. But still, the main risk factor for patients who present is smoking. There's about 35,000 new cases every year and about 19,000 deaths. So we have a lot of work to be done since many patients are chemo and treatment refractory up front. And this is a global problem. And in other parts of the world where there's a higher smoking incidence, this is still a cancer that accounts for a significant amount of lung cancer mortality. There are two main stages of small cell lung cancer, and today I'll be concentrating on extensive stage small cell lung cancer, which is actually what 75% of patients present with, which is disease outside the thorax that cannot be radiated all in one port. A lot of these patients can present with brain metastasis at baseline, and it's important that we select treatments that not only are effective systemically, but also that they have intracranial activity. The landmark treatment for extensive stage small cell lung cancer has not changed for many decades. We have started with chemotherapy, platinum-based chemotherapy, carboplatin, cisplatin, etoposide. And then in the recent past, we had the addition of immunotherapy to that first-line backbone with some marginal improvement in survival. So today I will be discussing what happens after that initial treatment with chemoimmunotherapy when patients progress. Although we do know that at least in the United States, only 30% of patients who progress after their initial treatment are candidates for second-line therapy. Now, where do we go after chemoimmunotherapy has been an area of a lot of research since small cell lung cancer, unlike non-small cell lung cancer, today doesn't have a targeted therapy option for patients. But there's been a lot of research trying to understand the genomic and transcriptomic features of small cell lung cancer. And different types of small cell lung cancer have been identified, including an inflamed subtype that may respond better to immunotherapy manipulation, including the POU253 inflamed subtypes. Now, there's been a rapidly changing treatment paradigm for small cell lung cancer. I will say in the last 5 years, more has happened in small cell lung cancer than in the prior 20. So since 2019, we have heard and have approval for combination of chemoimmunotherapy in the first-line setting with the Empower 133 data for atezolizumab and the Caspian trial for durvalumab. After that, we got one second-line therapy approved in 2020 called lurbinectedin, that is more of a cytotoxic therapy that was approved based on a basket trial. And what has been very exciting since 2024, which is just only barely a year ago, is the recent rapid approval of a new bispecific T-cell engager, which is a new type of immunotherapy approved for small cell lung cancer called tarlatamab. And there's a lot of trials of new therapies that are going to engage the immune system in different ways, and also antibody drug conjugates that are going to be selecting specific markers in the small cell lung cancer. So we are starting the era of more targeted therapy in small cell lung cancer. But just so I give you some reference, the chemoimmunotherapy, which is currently the standard for first-line therapy for extensive stage small cell lung cancer, leaves many of our patients with progression in their second year. So although there is a benefit of adding immunotherapy, the rate of overall survival at 12 months for patients in the Empower 133 data was only 51%. So a lot of patients progress on the first year and the second year, and we have a lot of room for improvement. And also the data for the durvalumab, which also was added to chemoimmunotherapy, also shows that the median overall survival is just barely 12.9 months.